This episode is brought to you by State Farm. Knowing you could be saving money for the things you really want is a great feeling. Talk to a State Farm agent today to learn how you can choose to bundle and save with the Personal Price Plan. Like a good neighbor, State Farm is there. Prices are based on rating plans that vary by state. Coverage options are selected by the customer. Availability, amount of discounts and savings, and eligibility vary by state.
Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in school and at the bedside. Before we hop into our topic today, which is about postoperative pediatric airway complications, let's take a quick minute for our listener shout out. And this one goes out to Joe, who says, I'm so thankful for Nurse Mo and her various resources. I especially appreciated Med-Surg Solutions. Her concise information, teaching style, and study guides truly helped me grasp concepts that the textbooks complicated. Thank you, Nurse Mo. As I come to the end of nursing school, I know you have helped me profoundly through this, and I anticipate continuing to utilize your incredible resources as a new grad. Well, Joe, thank you so much for reaching out and sharing your experience with all the things that I do and provide for nursing students to help you succeed. So if you're wondering what Joe is talking about, Med-Surg Solutions is an online program that I created to take all the complication out of Med-Surg. It is video-based and it has the most amazing downloadable study guides. I'll put a link in the episode notes so that you can check it out. Alrighty, so we're talking today about postoperative pediatric airway emergencies. So these pediatric emergencies in the post-op setting are high impact, very, very high impact events that can quickly escalate to cardiac arrest. Because what is the number one cause of cardiac arrest in children? It's respiratory failure. So it's really, really vital that you recognize and act on any airway issues immediately. Now, I do have an episode where I go over pediatric respiratory distress in greater detail. So if you are interested in exploring that topic, check out episode 140. Again, that was episode 140 to dive into pediatric respiratory distress. So in this episode, we're going to talk about some unique features of the pediatric airway, risk factors for postoperative respiratory complications in children, performing a focused pediatric respiratory assessment, signs of respiratory distress in children, which I'll weave into that respiratory assessment part, and some common post-op respiratory complications, including desaturation when their pulse ox levels drop, upper airway obstruction, specifically soft tissue airway obstruction, laryngospasm, bronchospasm, and oversedation with loss of ventilation. So definitely all things that you don't want to happen, but if they do, you want to be prepared. So let's first dive in and talk about some key differences between pediatric airways and adult airways. So the first thing to understand is that they're really different, like really, really different. They're not just smaller, there are some key differences. So of course, one of those is size. Not only is the pediatric airway smaller in length, it's also much smaller in diameter. And what this means is that even small obstructions or even mild edema can be extremely dangerous for your patient. So here's some point of reference. For an adult or a child over the age of 14 or so, that internal tracheal diameter is about 8 millimeters. Okay, so that's, if you're listening to this and you're 14 and older, that's the size of your internal tracheal diameter. A newborn, 2.5 millimeters internal tracheal diameter. A 1-year-old is about 4.5 and a 6-year-old is about 6. So very small in diameter and also shorter. Now, another key difference is its position. In a child, the larynx is higher and more anterior than in adults, which can make intubation more difficult. Also, the shape of the airway. Now, the airway in a child narrows at the cricoid ring, whereas in adult, it's going to be more narrow at the vocal cords. And then there's tongue size. That pediatric tongue is larger relative to the oral pharynx, making occlusion way more likely and intubation more difficult. There's also mandible size. The smaller mandible size in kids increases the risk for airway obstruction. And also their head size. You look at a little baby and they got that giant head. It's so cute. But that large occiput of small children, especially infants, causes them to flex their neck when they're laying on a flat surface. And this position can lead to airway obstruction. Again, this is more pronounced in infants with that larger occiput. And then large tonsils and adenoids. Large anatomical structures can impede on airway space. So lots of differences between pediatric and adult airways. Alrighty, what about risk factors for having respiratory complications in that postoperative period, like in the PACU after surgery? So postoperative respiratory complications are some of the most common events occurring in pediatric patients that undergo surgery. And it's probably the number one reason why I would be terrified personally to take care of a pediatric surgical patient. Bless every one of you that do this or who are interested in doing this and taking care of children. You are amazing. I would just be way too nervous. So looking at pediatric respiratory complications, I saw a study that estimated that of all post-op complications, 75% related to the respiratory system. And I also saw some articles in the Journal of Peri-Anesthesia Nursing and the Journal of Clinical Medicine outlining the many factors that predispose pediatric patients to post-op respiratory complications. And there are quite a few, so let's go through some of these. All right, so one is having an underlying respiratory condition. Upper respiratory infections, I saw that one a lot. That would definitely be included in this list. Reactive airway disease, asthma, pneumonia, any chronic lung disease, smoking. Remember, kids can smoke, and also kids can get exposed to secondhand smoke. So those two things as well. Having obstructive sleep apnea or pulmonary bronchial dysplasia. So anytime you've got a kiddo coming in and they're having surgery and they have any kind of respiratory condition, you want to be on high alert that they could be at higher risk for post-operative respiratory complications. Another risk factor is cardiac conditions. Kids with congenital heart disease, with arrhythmias, with murmurs, higher risk. Also, neurological conditions like seizure disorders, AVMs, and neuromuscular disease such as cerebral palsy could put the child at higher risk. Any physical abnormalities such as tracheal malacia, and then some kids have a small jaw with a large tongue that is placed backward. And I'm going to try to pronounce it. Don't make fun of me. Don't send me an email. Don't comment on it because I'm being very honest. I'm not sure how to pronounce this. Micrognathia with glossoptosis. If I didn't say that right, my apologies to the pronunciation gods, but it is a small jaw with a large tongue that is placed backward, going to place your patient at higher risk for post-op respiratory complications. Any genetic disorders is also going to increase that risk: cystic fibrosis, Down syndrome, Apert syndrome. And then a few that just kind of fall into an other category would be obesity, eczema, which I found surprising, but with a little more digging, I learned that eczema and asthma have some links together. So if the child has eczema, they maybe also have asthma, which would obviously be a respiratory condition. African American ethnicity, and this is due to a more narrow airway, and also having anemia. And then there are surgery-related factors. Some of these are kind of obvious. A longer or more complicated surgical procedure could put the patient at higher risk for post-op respiratory complications. Use of long-acting neuromuscular blocking agents, if it was a difficult intubation, especially with repeated attempts, and then specific types of surgery, including tonsillectomy, adenoidectomy, surgeries of the head and neck, and surgery for pyloric stenosis, though there were quite a few more. And then age. Preemies, infants, and young children are at higher risk than older children. And then there's something called the ASA score. Now, that ASA score is utilized by anesthesiologists to classify patients based on their medical history. And the scores range from 1 to 6, with 1 being a healthy patient with no issues, to 6 being a patient who has been declared brain dead and who is undergoing surgery for organ procurement. So, and within that range, there are, children with chronic disease that are well managed, or chronic disease that's a threat to life, etc. So the higher the ASA score, obviously, is going to put the child at higher risk for post-op respiratory complications. Now, I do want to have a caveat here that perioperative complications can occur in any child. So even if you listen to this list and you're like, well, my patients don't have any of those problems, they're not out of the woods. I saw a study that was conducted in Singapore that looked at 297 critical incidents and found that 80% of them occurred in healthy patients scheduled for elective surgery. Of these, most were respiratory-related events, with laryngospasm being the most common. And yes, we're going to talk about laryngospasm in a bit. Okay, so now let's talk about your pediatric respiratory assessment. So when you're assessing a child's respiratory system, whether or not they're in respiratory distress, you're looking at a few key components. You're looking at behavior, their gaze, their speech or their cry, their posture, their work of breathing, their respiratory rate, any sounds that you could hear, skin color, and heart rate and SpO2. So quite a few things. Let's talk about each of these a bit. So first, looking at behavior. Now, we're looking specifically here at post-op situations. So behavior is going to vary a lot depending on what phase of recovery that child is in. Immediately after surgery, when the child first comes out, they'll be unconscious or very, very drowsy. So that's abnormal behavior, but it's not abnormal for any unexpected reason, right? We expect them to be drowsy right after surgery or even unconscious. Now, as the child awakens, you're watching for a return to normal behavior. A child who is agitated and restless could be exhibiting this behavior due to hypoxia and respiratory distress. Of course, now it could also be due to pain. It could be due to emergence delirium, anxiety because mom and dad aren't there, whatever it is. What this means is that further assessment is necessary. Now, a listless child who is not interacting with their environment, that is a child in distress. In addition, if the child is drooling, this could be a sign of a partial or even complete airway obstruction. So you're looking at their behavior. Now, what about their gaze? If the child has an absent stare, that's not, obviously it could be because they're still coming out of the effects of anesthesia, but as they're waking, you're watching for that return of normal behavior. So if they have an absent stare, this could be due to hypoxia and altered mentation. So again, further assessment is necessary. How about speech and or cry? Now, in children that are able to talk, you want to pay attention to their speech. If they are unable to speak in full sentences or speak at all, and they normally do, that child is probably showing signs of respiratory distress. Further assessment is necessary. I sound like a broken record, probably. A child who has a weak cry or an absent cry is experiencing distress of some kind. And guess what? You're going to do more assessment. All right, let's look at the posture of the child. Now, of course, initially that child will be sedated. Just as you are watching for return of normal behavior, you're watching for return of normal posture once that child wakes up. If they are assuming, for example, a tripod position, or they're lethargic beyond what is expected for their stage of recovery, these are signs of respiratory distress. The tripod position is when they're sitting upright and they're kind of leaning a bit forward with the mouth open and the jaw and neck kind of thrust forward to open the airway. And they just assume this position naturally when they're trying to get more air. So you're looking at posture. You're also looking at work of breathing. So observe the child for increased work of breathing. This could be accessory muscle use, nasal flaring, grunting, or head bobbing. These are all signs the child is struggling to breathe, and you better hop on that incredibly quickly. What about respiratory rate? Now, tachypnea, not uncommon after surgery, right? People are in pain, they're anxious, they're scared, all of that. So the child could have tachypnea due to anxiety or pain or emergence delirium. But significant tachypnea or tachypnea that you can't ascribe, to an underlying cause, or tachypnea with accessory muscle use, definitely a sign of respiratory distress. Now, I will say that children, they're amazing and they're great at compensating. And that tachypnea is a compensatory mechanism, and they can do that really well. But guess what? They don't do it for very long. When they start to lose the ability to compensate, it will happen incredibly quickly and they will spiral and deteriorate fast, much, much faster than adults. So you're watching that respiratory rate. If they're tachypnic, you have to ask yourself, how long do I think this child can maintain that respiratory rate? The answer is going to be not that long. So you've got to address it very quickly. Now, if they can't compensate anymore, guess what they're doing? Now they're breathing too slowly. They don't have any compensatory effort remaining. That child's in serious trouble. In addition, any periods of apnea are also signs the child needs immediate intervention. We're also going to listen. Abnormal findings that we could hear with our ears include wheezing, stridor, rales, and diminished breath sounds. We could also hear no sounds, which is called a silent chest. And this indicates little to no gas exchange and indicates respiratory arrest is imminent. And what happens after respiratory arrest? Cardiac arrest. So if you're not sure the difference between wheezing and rales and crackles and all of that, let's talk about it very briefly here. So wheezing is air moving through narrow or collapsed airways, very common in bronchospasm and asthma. Rales or crackles is associated with fluid accumulating in the alveoli. And stridor is a high-pitched sound due to turbulent airflow through a narrow upper airway. And then diminished sounds. Again, it's just going to be very quiet or even silent, hopefully not, but that could happen in a total obstruction. And this is, due to obstruction, like I just mentioned, or airway narrowing. All right, so that was sounds that you're going to listen for. You're also looking at the child's skin color. A child having respiratory difficulty may appear pale or cyanotic, and pallor and cyanosis are typically most easily observed around the mouth and at the nail beds. Also looking at a couple vital signs, heart rate and SpO2. So what's going to happen to the heart rate initially when the child's having respiratory difficulty? It increases to compensate. As this compensatory mechanism fails, and it will, bradycardia or other very serious arrhythmias ensue and signify impending cardiac arrest. And then SpO2, a low oxygen saturation level, is a sign of respiratory compromise. That was kind of a freebie, but I wanted to include it anyway. So just to recap, for our respiratory assessment, we're looking at behavior, the child's gaze, their speech or cry, their posture, their work of breathing, respiratory rate, any sounds that we can hear, their skin color, heart rate, and SpO2. Now let's take a quick break, and when we come back, we'll talk about some nursing interventions for some pediatric respiratory complications.
This Memorial Day, turn up the heat with the Home Depot. Find the perfect grill and patio set to keep the cookouts coming all season long. Grill up a feast with the Next Grill 4-burner gas grill, only $229. And complete your space with the stylish Glen Ridge Falls 7-piece dining set, now on special buy for just $499 with free delivery. Take your Memorial Day cookout to the next level all summer long with the Home Depot. See homedepot.com/delivery for more details.
Okay, so we've talked about some features of the pediatric airway that make it different from an adult airway. We've gone over some risk factors that could put a child at risk for post-op respiratory complications and performing that focused pediatric respiratory assessment and some signs that you could see that the child is in trouble. Now let's talk about some common post-operative respiratory complications and what we're going to do about it. So first we have desaturation. And before I get into that, I really do want to stress that respiratory compromise in a child is not a no big deal kind of thing. It is a very big deal. That leading cause of cardiac arrest, as I mentioned earlier, in children is respiratory failure. So it's really, really important that nurses work to restore respiratory function as quickly as possible. So we're starting with desaturation or hypoxemia. So common causes of post-op hypoxemia include the residual effects of medications used in surgery and anesthesia. Or there could be inadequate reversal of anesthetic agents. There could be the use of opioids. The child could have an airway obstruction, laryngospasm, all kinds of reasons they could be desaturating. Another very common and avoidable cause of hypoxemia in pediatric patients is simply transporting the child from the OR to the recovery room without supplemental oxygen. I saw a study that said even short trips can cause the child to drop their oxygen saturation level, which is why as soon as that kiddo comes in, if they're not on oxygen, we're going to get them on oxygen. We're going to get them hooked up to the monitor right away and keep a very close eye on them. An SpO2 lower than 94% is considered hypoxic in a pediatric patient, and oxygen therapy should be increased or initiated if it has not already been started. And you also want to make sure that you're utilizing the oxygen delivery device that is best tolerated by the patient. And with that, address any other causative factors. So when I say the oxygen delivery device that is best tolerated by the child, do you think a 2-year-old is going to let you put a nasal cannula on them? No, absolutely not. So you will have to use different oxygen delivery devices. And in some kids, it's a blow-by device. And other kids, they might tolerate a mask or something like that. So you just have to, as you get more adept at working with children, you'll kind of know what oxygen delivery devices are going to work best for children of different ages. And then, as I mentioned, you also want to address any other causative factors. What's causing the child to be desaturating? For example, if the child is desaturating because they have a soft tissue airway obstruction or a bronchospasm, you want to get in there and address that. So let's talk about soft tissue airway obstruction. So soft tissue airway obstruction is another postoperative pediatric respiratory complication, and it occurs due to the posterior movement of the tongue and loss of upper airway tone. And that loss of airway tone and the movement of the tongue occurs because of anesthetic medications. Now, if this sounds absolutely terrifying, good, it is. It is absolutely terrifying, but the good news is in most cases, soft tissue airway obstruction can be managed with manual airway maneuvers or an adjunct like an OPA or an NPA. Now, an OPA is an oropharyngeal airway and an NPA is a nasopharyngeal airway. And note that when you are utilizing an OPA with a child, you're going to insert that with the device pointing down, with the tip pointing down, while the tongue is held out of the way by a tongue depressor. Now, in adults, we could do that method in an adult as well, but we often put it in the mouth upside down or sideways and then twist it as we place it. But twisting or turning the OPA in a child's mouth can damage the soft palate. So the preferred method in a child is to insert the OPA with the tip pointing down while you're using a tongue depressor to hold that tongue out of the way. Now, of course, if the airway is obstructed by thick secretions or blood while you're at it, you're going to clear the airway with a suction device as well. So if you want to learn more about OPAs and NPAs and managing airways, then you would love to go and check out an episode that I recorded recently. And that is episode 404. So if you want to dive more into OPAs, NPAs, how they're sized, how they're inserted, holding airways, how to do a jaw thrust, how to do a head tilt chin lift, all of that, I'll talk you through it in episode 404. So that was soft tissue airway obstruction, one of the most common things that you're going to see. As a nurse that worked in the PACU with adults, not with kids. Kids are too scary for me, but working with adults, this was probably the most common, definitely the most common respiratory issue that I dealt with. So very, very common post-operatively. The next is laryngospasm. Now, this is technically a type of airway obstruction that can occur in that post-op period. And it occurs as the child is emerging from anesthesia, and it involves an exaggerated protective vocal cord closure reflex. Other causes of laryngospasm include severe hypocalcemia, vitamin D deficiency, and gastroesophageal reflux. So laryngospasm can be partial or it can be complete, and it is considered a life-threatening emergency that can result in hypoxia, bradycardia, and what comes after the bradycardia? The cardiac arrest. So you might be wondering, what are the signs and symptoms of this? I want to make sure I catch it very quickly. Well, good for you. Okay, so the signs and symptoms of a partial laryngospasm are inspiratory stridor, suprasternal and supraclavicular retraction, so that accessory muscle use, they're trying to get air in, flailing of the lower ribs, and minimal air entry. So if you're in the recovery room, whether you're a student there, precepting for the day, or you're working in that environment and you hear that inspiratory stridor, you got to run over there quick. Now, a complete laryngospasm, the signs and symptoms there, definitely more ominous, no breath sounds. You could see paradoxical chest movement where the chest is moving opposite of what it normally would. The chest wall is moving in while they're trying to take that breath in and pushing out as they're trying to breathe out. So it's definitely going to look very abnormal. They'll have hypoxia, bradycardia, and no air entry. Now, with a partial laryngospasm, there was minimal air entry. With complete, there is none. So you can see how both of these are very, very serious. So you might be wondering who's at most risk for laryngospasm, and there's quite a few. And some of these match what we talked about when we talked in general about the patients at risk for post-op respiratory complications. But let's talk about it a little bit more detail for this particular complication because it is so serious. So risk factors for laryngospasm include the use of volatile anesthetics like desflurane, isoflurane, halothane, I hope I said that right. It might be halothane, I'm not sure, and sevoflurane. Also, vocal cord irritation by blood, mucus secretions. Apparently, these inhaled anesthetics irritate the vocal cords as well. Multiple intubation attempts. And here's a really key one, stimulation of the airway while the child is under light anesthesia or while they're emerging from anesthesia. So that means laryngospasm could be happening as the child is coming out of anesthesia, coming out of surgery. Age is also a risk factor. Infants and younger children are at higher risk, as are children with asthma. They're up to 10 times more likely to experience laryngospasm. Also, any kiddo with recent upper airway infection, who's exposed to secondhand smoke, who has OSA or GERD, they're going to be at higher risk. Also, any child with an airway anomaly or who had those high-risk surgeries like tonsillectomy and adenoidectomy, as well as bronchoscopy and endoscopy, just very irritating to that airway. All right, so now we know who's at risk. We know some signs and symptoms. What are we going to do about it? So first off, if we can remove the irritating stimulus, let's do that. So the first thing is to stop the irritating stimulus if we can. This is more a thing that would occur in surgery with the use of those volatile anesthetics. We also want to provide positive airway pressure with 100% FiO2. We can utilize a face mask with a tight seal and a closed expiratory valve. We can use a BVM. We can use CPAP to get that positive airway pressure with 100% FiO2. We could also try a vigorous jaw thrust, which can lift the epiglottis away from the glottic opening, moving the larynx forward and creating a gap between the vocal cords. And then there's another really cool maneuver called Larson's maneuver. And this is performed by putting pressure on the mastoid process behind the posterior ramus of the mandible. It's actually a very specific location. You may hear it called the laryngospasm notch. If you want to see what that looks like, I will put a link in the episode notes to a YouTube video showing exactly where this laryngospasm notch is so that you can perform Larson's maneuver. And apparently you got to put some pretty significant pressure here. And it, in a lot of cases, can break the laryngospasm. Nobody really understands why, but there you go, Larson's maneuver. And then medications. Propofol and succinylcholine may be used to break the spasm. Now, when succinylcholine is used, the anticholinergic will be utilized, such as atropine or glycopyrrolate, and that's because succinylcholine can cause bradycardia, and we don't want bradycardia because then that can lead to cardiac arrest in these kiddos. So just be aware, propofol and succinylcholine. And if succinylcholine is used, very likely they're also going to need an anticholinergic like atropine or glycopyrrolate. And these would be ordered by your anesthesiologist. So that is your overview of laryngospasm. Next is bronchospasm. So bronchospasm can occur due to stimulation of the airway from a device, like an endotracheal tube, for example. It can occur because the child has underlying reactive airway disease, or maybe they had an anaphylactic reaction to an antibiotic that they got in surgery, and it can occur due to aspiration. So bronchospasm can lead to respiratory deterioration due to airflow obstruction and definitely should be treated promptly. Signs and symptoms that you're likely to see include wheezing, frequent coughing, extended expiration, and general signs of respiratory distress such as labored breathing and accessory muscle use. And the treatment for post-op bronchospasm can include things like bronchodilators like albuterol. It could include glucocorticoids, and in some cases, the child may need high-flow humidified oxygen. So those are some orders or things that you might see come through for a child who has post-op bronchospasm. And then we have our last complication, which is oversedation with complete loss of ventilation. So in cases where an opioid or a benzodiazepine or inadequate anesthesia reversal has led to a complete loss of ventilatory effort, we got to act on this very quick to prevent bradycardia and impending cardiac arrest. So any patient without respiratory effort needs assisted ventilation. And a quick way to do that at the bedside is with the bag valve mask and 100% FiO2. Now recall that rescue breathing for a child, if you've done your PALS recently, your pediatric advanced life support, is 1 breath every 2 to 3 seconds. Now, while we're taking care of ventilation with the BVM, we're going to call for a friend to get us a reversal agent. If it's an opioid, what's that reversal agent? That is Narcan or naloxone. Very good. What if we think it was a benzodiazepine that put them over the edge and caused this lack of ventilatory effort? Excellent. That reversal is flamazanil. And if the child isn't adequately reversed from anesthesia, or if there was paralytic still in the IV line that dripped through after they got to the recovery room, then additional reversal medication will need to be administered by the anesthesiologist, and a common one is Sugamadex. Whew, okay, so we just went over a lot of really scary things that could happen in the post-op period. My goal was not to terrify you, but to make you or help you feel more prepared if something like this should happen, if you're a student in that environment, so that you can hopefully stay calm and hopefully there's a nurse nearby to help the patient. And if you do work in that environment, then you're possibly seeing these things. They probably make you nervous. I mean, they definitely should make you nervous, but maybe you feel a little bit more confident now. And if you want to learn more about pediatric nursing, I've got quite a few episodes covering stuff about peds. Again, episode, 140, talks about pediatric respiratory distress in general. And then I've got a whole slew of other ones. So I'll put a link in the episode notes as well so that you can go straight to my website where you can see a whole list of those pediatric articles or pediatric podcast episodes. You can also just go to the straightanursingstudent.com website and click on the menu bar, and it's pretty easy to find from there. All right, well, I hope this helped you, and I hope to see you back here again very soon. I've got some great episodes coming up for you, and to make sure you don't miss a single one, subscribe or follow the show on your favorite podcast player, and I will be in your ear again soon. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airway Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Hello, we want to recommend our podcast, don't we, Rowan?
We do, Penny. It's called The World, the Universe and Us from New Scientist, and it's your essential weekly dose of science and wonder. Hosted by me, Dr. Rowan Hooper.
And me, Dr. Penny Sarche. Each week we talk to the scientists in the news and draw on new scientists on parallel depth of reporting to put the stories that matter into context. It's brain food.
It's brain food. It feeds your brain and your curiosity, and it's a dose of optimism.
The world, the universe, and us. Get it wherever you get your podcasts.